Liver cancer.
Anything that increases your risk of getting a disease is a risk factor. Different cancers have different risk factors. Doctors and scientists do not know exactly what caused the liver cancer, but we know of some factors that can increase the risk. Cirrhosis means scarring of the liver due to previous damage. This scarring can cause problems with the way the liver works. Having cirrhosis increases your risk of getting liver cancer. The risk varies depending on the cause of the cirrhosis. Cirrhosis can be caused by infection with a virus such as hepatitis B or C, long-term alcohol drinking. Hepatitis virus are viruses that infect the liver. Two common types are hepatitis B and hepatitis C. People who have the hepatitis B virus face up to a 100 times greater risk of developing hepatocellular carcinoma. Although hepatocellular carcinoma actually develops several decades after infection. Viral hepatitis can be passed from person to person through exposure to another person's blood or bodily fluids. It can happen through injury, by sharing needles during drug use, or by sexual contact. Chronic infection with hepatitis B affects the liver cells. This stimulates the body's immune system to attack the virus. The immune response causes liver inflammation, which can lead to ongoing damage and can cause liver cancer.
Mechanism of MIR122 in regulating HBV replication, which is the most abundant liver-specific microRNA in liver. They found that MIR122 expression in liver was significantly down-regulated in patients with HBV infection compared with healthy controls. Loss of MIR122 expression leads to upregulation of its target cyclin C1. Thus, intravenous interaction between cyclin C1 and P53 and appropriate P53 mediate inhibition of HBV replication. MIR122 play an important role in hepatic function and act as a tumor suppressor.
HBV pathway. Hepatitis B is one of a few known paratovirus. The virus can enter into the cell by binding to NGCP on the surface and being induced cytosed. Because the virus multiplies via RNA made by a host enzyme, the viral genomic DNA has to be transferred to the cell nucleus by host proteins called chaperones. The partially double-strand viral DNA is then made fully double-strand by viral polymerase and transformed into cccDNA. This cccDNA serves as a template for transcription of four viral mRNAs by host RNA polymerase. The largest mRNA is used to make the new copy of the genome and to make the capsid core protein and the viral DNA polymerase. These four viral transcripts undergo additional processing and go on to form progeny variants that are released from the cell or returned to the nucleus and recycled to produce even more copies. The long mRNA is then transported back to the cytoplasm, where the variant P protein, the DNA polymerase, synthesis DNA where its reverse transcription activity.
Cell survival and proliferation by activation of PI3K and AKT via PTEN suppression by HBx. HBx expression in HBx transfect in liver cells modulate the transcriptional activation of PTEN by inhibiting function of p53 as a transcriptional activator, and also increase phosphorylation of AKT, which is known to be an important mediator of cell survival, proliferation, and growth. Hepatitis C pathway. Step 1. HCC retroviral particles enter target hepatocyte via receptor-mediated endocytosis. Step 2. The virus is coded by caprin and it releases genetic material into cytoplasm in liver cell. Step 3. Translation. The rich viral RNA is translated at the ear, producing a single polyprotein precursor that is cleaved by host and viral proteases. Step 4. Positive strand RNA is replicated by the viral RNA-independent RNA polymerase NS5B via a negative strand intermediate. Step 5. Newly synthesized positive strand RNA is encapsulated by the viral nucleocapsid core, and enveloped glycoprotein are acquired through binding into the ER lumen. Step 6. Lipoviral particles mature in the ER through interaction with lipoprotein. Step 7. It exits the cell via the cellular Golgi apparatus and infection occurs. When HCV infects two hepatocytes that cause inflammation and leads to liver cirrhosis, that is the common cause of hepatoma.
After hepatitis injury incurred by any one of several factors, hepatitis C virus, there is necrosis followed by hepatocyte proliferation. Continuous cycles of this destructive, regenerative process fosters a chronic liver disease condition that culminates in liver cirrhosis. Cirrhosis is characterized by abnormal liver nodule formation, surrounded by collagen deposition and scarring of liver. Subsequently, hyperplastic nodules are observed, followed by dysplastic nodules, and ultimately hepatocellular carcinoma, which can be further classified into well-differentiated, moderately differentiated, and poorly differentiated tumors. The last of which represents the most malignant form of primary hepatocellular carcinoma. P53 loss or mutation is shown to occur during procession to HCC.
Drinking more than around 5 units of alcohol a day increases the risk of liver cancer. Long-term heavy drinking causes cirrhosis and may also directly damage the DNA in liver cells. Non-alcoholic fatty liver disease is a group of conditions include mild hepatic steatosis and non-alcoholic steatohepatitis. In these conditions, fat builds up in the liver. The fat causes inflammation and damage.
The suspect mechanisms of hepatocarcinogenesis for various risk factors are shown. Commonalities are indicated using the same color. In addition to these mechanisms, hepatitis B virus and aflatoxin B1 share the characteristic of affecting the genome. HBV can integrate into the host genome, and aflatoxin B1 is a mutagen. HCV, hepatitis C virus. Smoking increases the risk of liver cancer. In smokers who also have hepatitis C or hepatitis B virus infection, the risk is increased further. Smokers who drink large amounts of alcohol may have a risk that is almost 10 times higher than people who don't smoke or drink. Children whose parents smoked before or during pregnancy have an increase of risk of a very rare type of liver cancer called hepatoblastoma. HIV and AIDS lower immunity. People with HIV or AIDS have a risk of liver cancer that is around 5 times higher than people who don't have HIV or AIDS. People with diabetes have a higher risk of liver cancer than people who do not have diabetes. The higher risk may be due to the higher levels of insulin in people with diabetes or due to liver damage caused by the diabetes.
Obesity leads to lipid accumulation and insulin resistance, which are caused to steatohepatitis and HCC. People who have their gallbladder removed to get rid of gallstone may have an increased risk of liver cancer. People from Africa and Asia who have eaten aflatoxin a long period of time have an increased risk of developing hepatocellular liver cancer. The risk is increased further in people who also have chronic hepatitis B infection. Stage and symptoms of liver cancer. Stage of liver cancer. Stage 1. There is a single tumor and the cancer has not spread to the blood vessel. Stage 2. It can be either a single tumor that has gone into blood vessel of the liver or several tumors that are less than 5 cm. Stage 3. This stage is divided into 3 further groups. Stage 3A. There is more than one tumor, and at least one of them is larger than 5 centimeters. Stage 3B. The cancer has grown into one of the main blood vessels of the liver. Stage 3C. The cancer has spread into organs close to the liver. Stage 4. This stage is divided into two further stages. Stage 4A. The cancer is any size and there may be more than one tumor. It may have gone into blood vessels or the organ around the liver. Stage 4B. The cancer may or may not have spread into lymph nodes, but has spread to another part of the body, such as the lungs or bones. Types of liver cancer have four types. The main type is hepatocellular carcinoma or HCC. That is primary liver cancer. It means that its cancer starts in liver. The others is cholangiocarcinoma, angiosarcoma, and hepatoblastoma. Hepatocellular carcinoma, or called hepatoma. It is a very common type of liver cancer, and approximately 75% people suffer from this cancer. Most of cases of HCC, due to the infection with cirrhosis or hepatitis B or C of liver, are caused by alcoholism. The symptoms of this cancer are easy bleeding, abdominal pain, and jaundice. Cholangiocarcinoma, or bile duct cancer. The liver makes bile which helps digest fat in food, and flow through tube called bile duct into the gallbladder. Cancer can start anywhere along the bile ducts. The symptoms of this cancer are jaundice, itching, weight loss, weakness, fever, and abdominal pain. Angiosarcoma. It is also known as a hemangiocarcinoma. It occurs about 1% only. It starts in its beginning through the blood vessel of the liver. The symptoms of this cancer are both skin infection and a lump. Hepatoblastoma is a malignant embryonal liver tumor that occurs almost exclusively in infants and very young children. It is most often diagnosed in children under 3 years old. Secondary liver cancer, also known as liver metastasis, develops from when primary cancer from another part of the body spread to the liver. Most liver metastases originate from colon or colorectal cancer. The symptoms of this cancer are fatigue, nausea, weight loss, and sudden loss of appetite.
Diagnosis. There are a number of tests used to diagnose primary liver cancer or secondary liver cancer in the liver. Blood tests show how the liver is working and whether there are tumor markers in the blood that might indicate cancer in the liver. The most common tumor marker is AFP, which are used for diagnosis liver cancer, but false positive rates for tumor marker tests are usually 5%. Imaging tests include a range of scans that allow doctors to see your organs and determine whether there are any abnormal tissue or tumors. Sometimes, non-cancerous lamps are found. Imaging tests for liver cancer are ultrasound, CT scan, which is used combined with PET-CT scan, and MRI scan. The biopsy is when tissue is removed for examination under a microscope. It is not done very often. If it is done using a fine needle or during surgery. If you have secondary cancer in the liver, you may also need tests such as colonoscopy or endoscopy to find out where the primary cancer starts.
Treatments. Treatment options and recommendations depend on several factors. First, how much of the liver the cancer is affecting. Second, whether the cancer has spread. Third, the patient's preference and overall health. Fourth, the damage to the remaining cancer-free area of the liver. When liver cancer is found at an early stage, liver works well. Treatment tries to eliminate the cancer. At later stage, liver doesn't work well. Treatment focuses on slowing growth of the cancer and relieving symptoms. This is directed treatments to eliminate hepatocellular carcinoma. These treatments are generally recommended when the tumor has been found at an early stage. First, surgery. Surgery is the removal of the tumor and some surrounding healthy tissue during an operation. the most successful disease-directed treatment, particularly for patients with a tumor smaller than 5 cm. If the tumor has spread outside the liver, or if the patient has other serious illness, surgery may not be an option. Hepatectomy. A hepatectomy can be done only if the cancer is in one part of the liver, and the liver is working well. The remaining section of liver takes over the functions of the entire liver, and may restore to its normal size within a few weeks. A hepatectomy may not be possible if the patient has advanced cirrhosis, even if the tumor is small. Side effects may include pain, weakness, fatigue, and temporary liver failure, and you can watch for signs of bleeding infection. Liver transplantation. This procedure is possible only when the cancer hasn't spread outside the liver, a suitable donor is found, and it is specific with a small tumor. After a transplant, the patient will be watched closely for signs that the body might be rejecting the new liver, or that the tumor has come back. The patient must take medication to prevent rejection. This drug can cause side effects, such as puffiness in the face, high blood pressure, or increased body hair. Thermal ablation. Radiofrequency ablation, RFA, and microwave therapy both use heat to destroy cancer cells. They may be given through the skin, through laparoscopy, or during a surgical operation, while a patient is sedated. Disease-directed treatments to improve survival. Chemoembolization. During chemoembolization, chemotherapy is injected to the catheter directly into a tumor using image guidance. The chemotherapy ducts are mixed with particles called microspheres which block the flow of blood to the tumor. Without a blood supply, the tumor no longer has the oxygen and nutrients it needs to grow. Chemoembolization may be used to slow tumor growth for people who are on the waiting list for liver transplantation. Targeted therapy. Targeted therapy is a treatment that targets the cancer-specific genes, proteins, or the tissue environment that contributes to cancer growth and survival. This type of treatment blocks the growth and spread of cancer cells while limiting damage to healthy cells. Anti-angiogenesis therapy. It is focused on stopping angiogenesis, which is the process of making new blood vessels. These agents will interrupt critical cell signaling pathways involved in tumor angiogenesis and growth. Because a tumor needs the nutrients delivered by blood vessels to grow and spread, the goal of anti-angiogenesis therapy is to starve the tumor. Other treatment options. Cryosurgery. Cryosurgery is a technique utilizing sub-zero temperatures to destroy tumors. In most cases, the tumor is destroyed but not removed. The technique involves the placement of one or more probes, cryoprobes, into the tumor, using ultrasound to guide the placement.